tell, because we really don't do much with parental nutrition in this class, I reposted the slides, basically what we got through, which is really the only take home that you need from this class. So we're just gonna pick up where we left off in parental nutrition next semester. So you'll only be required to know what we covered in class for parental nutrition, okay? I did post a key for the activity that we went through on Monday, and then I also posted some, some extra examples for extra examples for you to work through as well, so that you can continue to practice, since that will definitely be on the exam. All right, so any questions or last minute questions on nutrition support before we officially move into life cycle? Nah, we're good? All right, let me get my setup going here. Alright, so today we're going to start talking about pregnancy and lactation. And I have quite a bit of material that I'm expected to cover, so we'll be talking very fast today. And hopefully we can get through it all. All right. Okay. No, because my projector is slow to warm up. That's okay. We can get started. All right. So today I'm going to be talking about nutrition during pregnancy and lactation. And this is my area of research and interest in terms of nutrition, but it's really interesting. I've given this talk multiple years now, and I actually used to give it when I was doing my PhD at Davis, but it wasn't until last year that I felt like I really understood everything, seeing as that I just had a baby last year, and actually went through the pregnancy and lactation process. So this is a really fun lecture. It's just a lot of jam-packed material, so I will take as many questions as I can, but I might have to cut questions off just so that we can cover everything. And then I can always answer questions afterwards. So yes, obviously this is me. This was literally not even a week before I delivered. This was me before my crazy ultra marathon when I was 7 months pregnant with Adam, and this is Adam right after he was born. So these are my babies. So we're gonna talk about nutrition during pregnancy, and I just want to point out, isn't my mom rocking that 80s hairdo and outfit there? She was quite the hot mom, but really, here's me compared to this little baby right here, right before I took him home. And everybody at first was like, "Oh, he looks just like Lenny," but really, he looks just like me. To be honest, I have a couple side-by-side shots. Actually, I think he's pretty much a good mix of both of us. Nose up, he's completely me, but mouth down, he's Lenny. Next talk, you'll get to see some more nowadays pictures of Adam. But anyways, okay, so let's talk about nutrition during pregnancy. So the whole theory about nutrition during pregnancy, and kind of my area of interest for research and stuff that comes up in the literature quite a bit, is really taking a look at this hypothesis called the Barker hypothesis, or the fetal origins theory of adult disease. Has anybody ever talked about this or heard about this in any of their classes? Basically, the premise is what happens in utero has a very long-lasting effect for long-term health outcomes, health and disease outcomes. So the Barker hypothesis was originally kind of set forth by David Barker. He's a researcher in England, and basically he saw this relationship between babies that were born low birth weight, and then he followed them for many years and saw that those babies that were born low birth weight had higher rates of heart disease and diabetes issues. And so they started investigating this kind of relationship of, okay, well, what was going on during pregnancy that might be programming or might be setting the stage for this infant to kind of adapt to this environment and then set them up for later in life when they're introduced to the real environment. So there's a lot of really cool and interesting research looking at what's going on during pregnancy and long-term health and disease outcomes, and not just in nutrition. There's a lot of research looking at environmental exposures like pollution or any toxins, as well as just like external stress. And there's some really cool evidence to show that really what goes on during pregnancy or even right before pre-pregnancy can really have these long-lasting effects. So a lot of when we're thinking about nutrition during pregnancy, not only are we thinking about the immediate, what's going on during proper development, we want a healthy mom, healthy baby that to be delivered, but we're also thinking long-term, like what are we doing in terms of setting the stage for these long-term health indicators. Okay. So taking a look at nutritional status and pregnancy outcomes. So if we're thinking about preconception, so this is before a baby, is even there or even made. If you have severe malnutrition or poor nutritional status, more often than not, it's in the form of amenorrhea, meaning if a woman is not able to have a period, which means that she's not able to be fertile, so she can't actually carry a pregnancy. So that would really decrease fertility. So if you are prenatal, meaning you are pregnant and you have severe malnutrition or poor nutrition, you're at higher risk for miscarriage and stillbirth, meaning that you carry the baby to term, but unfortunately the fetus and the baby is not alive, which is very sad and very scary. So many times we are looking to augment that and make sure that we are entering pregnancy into a healthy state, not only to improve fertility issues for those that are looking to become pregnant, and then also to carry a baby to term that's healthy, as well as for the health of the mother. More often than not, though, we're really in this kind of moderate nutrition status range, and this is where you really see those long-term concerns, okay? First of all, moderate nutrition and health status can cause a lot of complications for pregnancy. You can be at risk for preterm delivery. We're going to talk about some terms that refer to what is a normal term. When someone says they were a term infant, what does that mean? That means you deliver around like 40 weeks, 37 weeks. If you were preterm, typically that means that you were delivered before term, meaning that you have higher risks, not only as a mom, but the baby as well, because they just didn't get that full gestation period to develop, to be able to face the outside world. Also what low birth weight means. We're going to talk a little bit about intrauterine growth restriction, which is basically stunted and or wasted. They have quite a larger risk of being of mortality than normal birth weight infants. We'll talk about birth defects, also perinatal morbidity and mortality, so post-delivery, and then again, just these longer-term adverse health consequences that we're going to see later on. So this is a very basic biology, like high school overview. Does everyone remember what happens during reproduction? Okay, remember, so we get half of our genetic information from a sperm and a half the genetic information from the ovum or the egg, right? So during fertilization, you have the joining of the two, and then basically, we can go through step by step. You have ovulation, where the egg from the female is released, and then fertilization happens when the sperm and the egg combine, and then you start to get the replication of DNA as well as the division of the egg, and then when you're at that stage, it's called a zygote. And then as you continue on through the fallopian tube to embed into the uterus and uterine lining, you have something that's called a blastocyst. And the blastocyst is what's actually implants into the uterine lining, and that's where you start to form the blood vessels into the uterine wall to create that new circulatory system that's going to be the connection between the mom and the baby. Okay, so there's a lot of really cool research taking a look in the infertility world about how to like maximize this environment to make sure that eggs are viable, sperm are viable, that the fertilization process happens, also the implantation process happens. So there's a lot of really interesting things. So if anyone's interested in reproductive health and reproductive biology, I would highly recommend going into this field. It's very cool. So when we talk about nutritional insults, though, we really need to take a step back and think about when development is happening and when you might see a lot of the more major insults, we should say. I shouldn't say insults, but a lot of those like greater effects if you are overnourished in some aspects or undernourished. And more often than not in the literature, you see more information about being undernourished or malnourished or missing certain nutrients that impact development more and more just because of our overweight and obesity issue in the country, as well as the rest of the world. You are seeing more papers coming out taking a look at those individuals and how they are directly affecting these different developmental milestones. All right, so when we just talked about the fertilization, zygote to blastocyst stage, that is really only in the first couple of weeks of a pregnancy, right? So they're not super susceptible to any toxic agent. So that would mean like there was too much of one thing. At this stage, really during DNA replication and such, unless you had somebody that was hugely malnourished, normally what happens is that they would just spontaneously abort. And many individuals actually have spontaneous abortions and we don't even know it. And it's not like, there's extra bleeding or anything involved. It just means that the pregnancy never really took. It's actually quite amazing to think about how we actually do get pregnant, because in a typical female cycle, there's only really like 5 days of a window that really are your most fertile, and of those 5 days, one is like the key period. Anyway, so when we're thinking about when we're actually pregnant, most people don't know that they're pregnant until about 4 weeks post, and that is because either if you are planning to become pregnant, you're keeping a watch for to make sure that you have the return or no return of your period, or if you were not planning to become pregnant and you realize that you didn't have a period, that's when people are like, usually I have my period every 4 weeks, so it's time to probably investigate and check this out. So by 4 weeks, though, you can see that you're going to start to have some major structural abnormalities take place if you are toxic or deficient in some nutrients. Okay, so by week 3, you're actually starting to see not only the central nervous system, but your heart, your limbs, eyes, and ears really starting to take effect in terms of development. And then you can see from weeks 3 to 8, really a lot of your development is starting to take place, and you're going to see some pretty major insults if you are lacking or have an overabundance of certain nutrients. Okay. As you get later on in pregnancy, you do have some physiological defects and some minor structural abnormalities, but really it's this key time point that we are trying to focus on capturing women to be at their healthiest, to make sure that they are providing a good healthy environment for developing baby. So if you again think about like just timing, okay, so by 4 weeks, if you didn't know that you were pregnant, or let's say that you had abnormal periods, or you were switching birth controls, if you're on oral contraception, you could get out to 5 or 6 weeks before you really think about, what might be going on. And by that point, it might be a little too late, and you may have imposed some lasting effects. And so it's going to be key when we talk about folate supplementation or folic acid supplementation later on in the talk. Okay, in terms of what you need to know for this slide, are you going to have to memorize that weeks 1 or 2 is a zygote and this is an embryo and this is a fetus? No, really you just need to think about the time frame of, that we really want to capture women primarily before they're pregnant, but we really need to make sure that earlier on in pregnancy, weeks 3 to 8, that's going to be where the majority of our developmental abnormalities can take place if you have somebody who's severely malnourished or has poor nutrition status. All right, so let's talk a little bit more about where the nutrients come from for the baby and kind of how that works. So this is, again, kind of like a biology high school reminder. So we have this amazing organ called the placenta. So not only does the mom grow a baby, but she also grows a whole new organ called the placenta, which is literally an amazing sack of nutrients, and where the blood flow goes back and forth in through the umbilical cord to the fetus to provide nutrition. Okay, so there's also some really awesome research finally going on with the placenta to kind of take a look at not only a little bit more of how it works, but what happens in pregnancies where you have insufficient placental flow, meaning for some reason there is constricted blood flow or constricted flow from the placenta to the fetus, why sometimes placentas don't form correctly, because of this restricted flow, does that contribute to hypertension, to the baby, to the mom? So there's a lot of really interesting research, but essentially what the placenta is kind of the nutrient sac that is providing, a plethora of nutrients and oxygen and hormones and such to the baby from the maternal blood. It's kind of like the gateway, think about it that way. Almost like the liver, but for the fetus, even though the fetus has a liver, but this is kind of like the first stop. So our bodies are pretty efficient in making sure that we're protecting the pregnant woman, particularly the fetus. You're kind of, for lack of a better term, programmed to be able to procreate, and so our bodies are very efficient at making sure that we're protecting that developing baby at all costs. Okay, so any quick questions before we talk about birth weight? And yes?
Is that why some moms drink their placenta after the baby?
That is very interesting. So I don't know if you heard that question. So Sophia asked, is that why some moms drink their placenta or eat it? Some people get it dried and put into capsules. So this is actually a trend that is coming back into favor. In the 80s, actually, when my mom had my brother and I guess it was also a thing to eat your placenta or to bring it home and like plant it in the backyard because it's really just like a sack of nutrients. I remember like Matthew McConaughey, when they had their baby, everybody freaked out because they were like, we're gonna take our placenta home and plant it, like, and everyone was like, that's gross, why would you do that? And nowadays everyone's like, I eat my placenta. Yes and no. So basically, because it is just a great sack of nutrients, that yes, that is kind of the thought, is like, why not continue to provide that? But there's a lot of unclarity of the safety issues of that, and also when you start to take out that organ and then process it and dry it, you do have some loss of nutrients, and a lot of times it's just very expensive. If you talk to any OB, they're pretty open to say that's kind of your choice, but that's not a recommendation from us. And again, like, we can't really say the safety. We don't know all the companies. It's not something that's done through the hospital though. And usually you have to special request it ahead of time because typically they, especially if you have any signs and symptoms of placental insufficiency, or they just want to do pathology on it to make sure that it was working, you have to like request to actually like take it out of the hospital. So yes, and usually you have to like have your own transportation system for it. You have to like store it. Anyways, so, but yes, essentially people consume their placenta for the nutrients. Okay, so birth weight. So birth weight comes up a lot in the literature and a lot when we're thinking about mortality and morbidity risk. Because it's a very easy indicator, right? Everybody gets weighed after birth, hopefully. And it's also been shown in the literature over and over again, these patterns of lower birth weight and higher risk for not only like immediate, like short-term, very early postnatal medical and nutritional complications, but also long-term as well. So a few terms to keep in mind. So when we say that someone's a preterm baby, and we're going to talk about term a lot in the high-risk infants, or high-risk pediatric talk that I give in a couple weeks. But when we talk about preterm, we're talking about any babies that are born before 37 weeks. So 37 weeks and up is considered term. So even though most people talk about pregnancy being 40 weeks, which actually technically is 10 months, even though everyone says 9 months, if you deliver at 37 weeks and above, you're considered term. So I delivered at 38 weeks and 6 days, I was considered term, even though it wasn't the 40-week cutoff. And I should say anywhere between 37 and 42 is considered term. They don't usually let women go past 42. It's very uncomfortable. Low birth weight is defined as being less than 2,500 grams at birth or less than 5.5 pounds. Okay, very low birth weight is defined as being less than 1,500 grams or 3.3 pounds. Okay. And then we have this term called intrauterine growth restriction, which are infants that are small for gestational age. So this is a little bit different category, and we'll get into that again a little bit more in the high-risk peds talk, but just to kind of keep it in the back of your mind in terms of pregnancy, it's when, if you take a look at infants that are born, we have the growth charts for when we're pediatrics. If you look at those that are born, they compare them at like how far along they were. So let's say you have somebody that was born at term, like 37 weeks, but compared to what the average is, they're actually smaller. So even though they were born at term, they could be smaller, okay? So they're not premature, they weren't born early. Okay? Function and growth potential is likely to be compromised below 3,200 grams, so about 7 pounds. However, that doesn't mean that every baby that's not born at 7 pounds is not gonna be healthy. It's just when you start taking a look at these very large studies and kind of group the numbers, it looks like those that are usually less than 7 pounds. Adam was 6 pounds. He was fine. Although, like, according to the OBs, we had IUGR. According to the peds, we did not have IUGR. He was term, but he wasn't that small. I don't know. There's a lot of, like, not 100% congruency between definitions, but he was healthy, didn't have any problems. So you can have babies that are born less than 7 pounds, and they're just fine. Okay, you have babies that are born greater than 7 pounds that do have issues. So it's a range. Okay. All right, so let's take a look at like what babies would look like if they were low birth weight versus normal birth weight. So these are 2-day-old infants. This would be low birth weight babies. This would be a healthy, normal birth weight baby. Okay, so you can see that obviously, just even a quick look, fat stores are pretty low on both of these. We've got some pretty little, skinny little legs. Same with around even like the cheeks area, a little bit, not necessarily wasting, but there's just a big difference in terms of your fat accumulation there. So again, low birth weight can have an increased risk for perinatal mortality. So meaning if you have a low birth weight infant, you have an increased risk for, unfortunately, for death, anywhere from 28 weeks gestation to 4 weeks postpartum. Okay, so that's why throughout your pregnancy, and that seems kind of weird because you're like, wait a minute, hold on, but you won't know that you're low birth weight until you deliver. But really, as you are a pregnant woman, if you're regularly going to the doctors, they are regularly actually looking at they're taking the length and the circumference of your belly to make sure that you're actually also gaining weight and growing appropriately. And if you don't stay on track, they usually will do a little bit more imaging, like an extra ultrasound, to check and make sure that the baby is growing appropriately. So this actually happened with me with Adam. When I was 35 weeks, I started measuring at 33 weeks, and they were like, okay, well, you're a petite person, so you might just be small, so he just might be small. But then when I got to 36 weeks, they were like, all right, you're still only like at 34 weeks, so we're gonna have you do an ultrasound. So they did the ultrasound to actually measure him, to make sure, and at that time we didn't know he was a him, but they wanted to make sure that he was still growing. And they did find that when I was at 37 weeks that he lengthwise was okay, but his abdominal girth was not. And so we actually had to discuss whether or not we were going to need to induce and have me deliver him early, because they didn't know if like my placenta wasn't working well enough to be able to provide enough nutrients to get him to be able to continue to grow. So you are closely monitored, and that's why you can have a higher mortality risk if you continue to have a baby who's low birth weight. Okay. Long term, you can have higher risk for illnesses, lower IQ, lower stature, and cardiovascular disease and diabetes later in life. I was not induced. Adam came out just fine on his own, a little too quickly as well. I actually didn't make it to the hospital, and my husband had to deliver him. So lucky for me, he delivers babies. But we were not. My doctor like gave me a hard time because she's like, you're probably one of the few like Bay Area women that like don't seriously consider a home birth, and I'm like, no. Not, I am so supportive of anybody who wants a home birth, but working in a children's hospital and seeing everything that could go wrong, I'm like, no, I'm going to be in that hospital just in case something happens. But that didn't happen. My brother and sister-in-law love to give me a hard time. They're like, you gave birth to a baby in a bathroom. I'm like, yes, I did. But he was healthy. He was fine, so he's good. But anyways, so yes, I could not be induced because he decided he was just going to come out anyways. So talking about consequences of IUGR. So again, this is that being born at term, but being small. Okay, so you have increased neonatal morbidity and mortality. Okay, and being preterm and low birth weight, so that's not even IUGR, that's just being born early, and being small carries the highest risk. Okay, so those babies are typically in the NICU for a little while because they do need, and NICU stands for Neonatal Intensive Care Unit, so it's the nursery that's set up to help babies who are high risk or having medical complications, to help them be able to continue the rest of the development that they need that they would have gotten while in utero. And typically there's usually permanent growth stunting in babies that are IUGR. Okay, and you do see deficits in cognitive performance greater than 2 years old. You do see overall reduced strength and work capacity into adulthood. So if you start thinking about even larger term implications of this, let's say that you have a population that malnutrition during pregnancy is an issue, and so then you have multiple babies that are being born IUGR, and then multiple adults then with reduced cognition, reduced work strength, reduced capacity, not being able to be out in the workforce. That can have some very large implications like economic growth for that population if it's a certain country and such. So there's actually some interesting research taking a look at different countries that have different birth populations. Increased risk of chronic disease, this is again directly reflecting the Barker hypothesis. There's also some questions about whether or not, and stunted adults produce more low birth weight babies, so their bodies don't have the capacity to support regular birth weight. Not in every case, that's why we have medical intervention, but a lot of times it is difficult for them to have normal birth weight babies. And then there's this question or not, or whether there's an earlier age of death, and not so much that like how can you tell if they die early, but is it more because of the birth weight that would be causing the earlier age of death, or is it these other factors that's contributing to the shorter lifespan? Yeah.
Is the point about producing more low weight babies, is that due to just like size or something physiological?
Possibly both. So it could be size, could be physiologically, it could be just the environment if they're not in an environment that is supporting that. When I say supporting that, meaning proper nutrition, proper medical care. So there could be multiple things going to that. So that's why I say it's not necessarily that they always will, but in the literature you see that most stunted adults have a hard time producing normal birth weight babies. Yeah.
Are there different ages for like twins?
Yes. Yeah. Twins are in a completely different category. Yes. We only talk about twins like this much just because we have so much other content, but there's a whole set of a different set of guidelines for birth weight outcomes, also for term outcomes. Even though it's ideal to be able to carry both babies or triplets, multiple babies to term, a lot of times they do deliver earlier, so there's like slightly different cutoffs for that. What was the other one? Nutrient needs, like specific nutrient needs are different because you have two or more pregnancies at the same time. So yeah, no, definitely. All right. One other really great example of an unfortunate example, but it really gave a really good clear-cut relationship between this particularly malnutrition and disease later in life, was something that came out of a series of studies about the Dutch famine. Has anybody ever talked about the Dutch famine in any of their other classes? Heard about it? Katie has a little bit, yes. So the Dutch famine essentially was this time period during World War II where you had this population, this Dutch population, that experienced, basically there was a blockage and they had severe malnutrition because there was no provision of nutrition, food, what have you. So during this time, they were able to collect and see babies that were exposed to this famine, either in late pregnancy, middle pregnancy, or early pregnancy. So the famine took place between 1945 and 1946. So these were the babies that were unexposed, meaning they were born before the famine. Okay, these were the babies that were unexposed, meaning they were conceived and born after the famine. So this is during the famine. All right, so if mom with a baby experienced during pregnancy in late gestation, so like the last trimester, this famine, their babies at adulthood had issues with glucose intolerance. If they experienced the famine mid-gestation, not only did they have these adults later in life have issues with glucose intolerance, they had issues with microalbuminuria, and then they also had more issues with obstructive airways diseases. If these babies were exposed early, so again, this is within the first 12 weeks of pregnancy, the first trimester, they had later on in life glucose intolerance, atherogenic or lipid or fat blood profile that was indicative of more heart disease risk, altered blood coagulation. Women, adults had issues with obesity, stress sensitivities, more heart disease, and breast cancer. So again, this was not a randomized controlled trial where they like introduced famine into these women. This was a natural experiment where they went back and saw this population. That's one of the things that's a little tricky with doing pregnancy research, is that if you're going to do an intervention that may affect the development or health of the fetus, yeah, you can't really do that. So it's a sensitive population, but this was a unfortunate but nice example to show, again, supporting that what goes on during pregnancy can really have a long-lasting impact. All right, so thinking about IUGR again, there are three major factors that can contribute to IUGR. There's a lot of factors that can contribute or cause IUGR, but the three that kind of fall under are maternal factors, fetal factors, and then placental factors. Okay, so issues coming from the mom, the baby, the developing fetus, as well as the placenta itself. Okay, so if a mom has any certain medical conditions that are causing extra stress on the pregnancy, maybe higher blood pressure, if she contracts some sort of infection or has one at baseline that could affect development, if she's already has pre-existing malnutrition and enters the pregnancy already malnourished, and then any other social considerations, so social support, access to food, access to proper nutrition or medical care that could contribute to IUGR. Fetal factors are oftentimes, kind of already inherent, meaning if there are genetic or chromosomal or congenital malformations that would impose improper development. Parity, so multiple pregnancies, twins, triplets, what have you, can also impose IUGR, especially if, it's a little hard to explain, but especially if like one twin or one of the babies, like their placenta forms correctly, but the other one doesn't, and so you have one that's getting a good amount of nutrition, one that's not. If only one placenta forms and you're getting it from both. So there's a lot of different factors that go into the parity portion of that. And then finally, placental factors, so placental insufficiency, meaning the placenta is not able to get proper blood flow, oxygen flow to the baby, or anatomic problems, meaning it wasn't formed correctly, so it was smaller, it was abnormal, part of it's not working. That's what it refers to what a placental factor causing IUGR could be. All right, questions about weight gain in pregnancy. Or sorry, birth weight. We're moving on to gestational weight gain. Okay, so weight gain during pregnancy. All right, so weight gain range depends on BMI at conception. So the Institute of Medicine, seems like it's a little bit old now, but this is actually, they review this every year, and we still go by the IOM 2009 guidelines, is that we take a look at what the woman's BMI is at pre-pregnancy, and then that's where we have our recommendations for weight gain. So I have a chart in a couple slides to kind of see where you fall for that. Larger women can gain less weight and still have a normal birth weight. So if you are larger, meaning a BMI of, let's say, over 25, and even the obese BMIs, you're recommended to gain less weight compared to somebody who has a lower BMI. Even though that seems strange to think, to be like, well, shouldn't everybody still gain the same amount of weight to be able to support a healthy pregnancy? Less weight being gained for larger women, you can still have very healthy pregnancies. Thinner women do need to gain more weight, otherwise they're at higher risk of having a low birth weight infant. So it is really important to make sure they gain enough weight. And also maternal size is a conditioning factor on placenta size as well, which also probably contributes to the low birth weight or stunted adults having low birth weight infants, is that if you have a stunted adult, you may not be able to actually get a big enough placenta size to be able to provide enough nutrition. Okay. All right, so when we think about birth weight as a function of maternal weight gain, so let's look at this is more kind of shows the trajectory of, like, if you were to have a healthy pregnancy, what is the rate of weight gain that you would need to achieve that? So those that are underweight or less than 18.5 BMI, as you can see with the steepest curve here, you would want to gain the most amount of weight, whereas very overweight individuals, it's very steady, it's very minimal. But again, you can still have a healthy baby weight, birth weight. So here's the breakdown of that, categories of per BMI. So if you have somebody who is less than 18.5 or has a low BMI, typically you counsel in the hope to have them gain anywhere between 28 to 40 pounds. Normal BMI, 25 to 35 pounds. High BMI, so overweight range, 15 to 25 pounds. And obese BMI is 11 to 20. Now, a lot of times women just don't have control over this. I know it sounds weird, you're like, so why do we have these recommendations anyways? Usually we're checking in on certain factors to see that what might be contributing to lack of weight gain or too much weight gain. But I've had friends that are super healthy, like they are eating everything right, they're getting enough energy, they're not overdoing it, they're not like binging out because they're pregnant, which is a very common theme is that I'm eating for two, so I need to eat more, which is not okay. That's not right. And they still gain over 35 pounds of their normal BMI. Like I have one friend, she's very petite, dietitian, healthy, and she was like, every time I go into the doctors, they're like, you've really gained a lot of weight. You're definitely outside the range. And she's like, I'm not even doing anything. I'm exercising even. And so sometimes it's just what happens. So usually you're trying to work with women just to kind of identify if there are any factors. So I had another friend who was a nurse who she entered her pregnancy with a pretty high BMI, and she actually enrolled in this study at Kaiser where she met one-on-one with a dietitian like every week, and she checked in to make sure that she was gaining appropriate amount of weight and eating well and exercising to see, if that sort of intervention really does help with minimizing the excess weight gain in women that were entering pregnancy obese. So, for her, I'm pretty sure it did because she didn't gain that much extra weight for her pregnancy. Okay. Oh, yep.
So the woman you talked about who was gaining or gaining too much weight even though she was doing like all the right things, is that just hormonal usually? Or?
Yeah, it's usually hormonal. Usually some women are just much more efficient at putting away when I say putting away, like storing fat reserves for later. Even Jasmine, like she was like, I've definitely gained over 35 pounds. She had the baby yesterday, by the way. Yes. She's like, I definitely gained over 35 pounds, and I've been like, she was like hiking every week at the end, like she eats very balanced. She's not a big like dessert sweet fan. She's like, I'm not even like eating a lot of extra sugar or anything. And she's like, I'm just putting on so much weight. So, and a lot of it was in different places. So like for both Jasmine and my friend Rachel, they got a lot of fat stores in their boobs right away for milk production. And like for my other friends that have put on a little extra weight, more often than not, it was more like all baby. It wasn't necessarily like I put on extra weight in my thighs or like in my butt or anything like that. It really was more pregnancy related weight. And that's another thing they look for, is to make sure that like, if you are putting on extra weight, is it really pregnancy related weight, or is it also like fluid accumulation? That's the other thing they have to worry about as well.
Weight then like more midsection, like provide cushion potentially?
Some of it, yeah. It depends on where the baby's being carried. So sometimes like you'll have some women that like go like more outwards, or they go out this way wards. So yeah, but yes, the like breast related weight is ridiculous. Personal experience.
Correlations to like fat stores go for any studies on it?
Of where the majority of fat stores go for. Oh yeah, we're gonna talk about that. Yeah, in just a second. That's a good question though, because you're like, if you're gaining, that much weight, not only part of it is coming from the baby, part of it is coming from fluid, but a lot of it is fat deposition, especially in the mammary glands to prepare for lactation. Okay. So again, this is to take kind of a look at what's the trajectory of weight gain during pregnancy. So again, let's take a step back and think about like what's going on developmentally from a developmental milestone perspective. For the first like 8-ish weeks, 8 to 12 weeks, there's not too much developmentally that's going on with the baby where they're growing really big. And if anybody's had any friends or family that has like, they get that like fruit of the week, like for like what size your baby is, like when you get up to like week 12, you're like, cool, I got a pea still, or I got a blueberry still. So in the first trimester, your weight gain should be very minimal, and a lot of it is attributed to blood volume increase, which we're going to talk about when we talk about physiological changes. It's really when you start to get to the second and third trimester that you get the more rapid and more accelerated weight gain, because you actually are depositing more fat, growing a baby, you're getting much more involved in terms of organogenesis. So going back to your question of where like the fat and weight is stored, so when you think about a healthy sized woman, typically 7.5 to 8.5 pounds will be coming from the fetus itself. 7.5 is going to be stores of fat and protein, usually within the breasts, obviously all over, but for the most part around the abdominal area. 4 pounds of that is actually blood volume increase, so it's a pretty big amount, and that's because you are building a second circulatory and vascular system for somebody. Your uterus and your tissues and fluid amount also goes up, but your uterus also increases size quite a bit. And so you're up to 2 pounds just from the uterus alone, 1.8 for amniotic fluid, 1.5 for the placenta and the umbilical cord, and then at least a pound coming from your breasts, if not more. Yes.
Does, like, if a mother's anemic,
Mm-hmm.
do they have to go to circulatory system?
Yeah, we're gonna talk about that. Yes, yeah, because that is definitely a concern that we try to address before getting pregnant, and then if it can't be addressed before, then it is treated during pregnancy because you can see issues with anemia. Yes.
So when women are losing weight after pregnancy, they're really only trying to lose the fat and protein source,
Yeah,
right? So
yeah.
all the other stuff kind of just.
Yes. Yeah, exactly. So that's why we worry about putting on too much weight. 'Cause if you are putting on too much weight during pregnancy, it may be that you're not actually putting on pregnancy weight. You're actually accumulating as if you were like not pregnant and just gaining weight. Because when women lose weight after pregnancy, most of it's coming from this fat and source of fat and protein that you accumulated just for pregnancy. A lot of it really for milk production is the biggest bank is what it's for. That's a good question. So, and it's very individual for different people and how quickly you lose that weight. Some people, it comes off very quickly. Some people, it can take a little bit of a while for it to come off. It is definitely a fallacy that breastfeeding makes you just have the pounds melt away. With some people, it does really work that way. For other people, it doesn't. So it's very individual.
Is it possible? Yeah, with breastfeeding, your body is like secreting hormones that then it's telling you to keep the weight on. So do you need those?
Sometimes, yes, yeah, and then also balancing out with how much the woman is actually eating because it is a very high energy consuming process, and we'll talk about that the last little part of the talk today. But you can have individuals that that like are like just so hungry that they're actually like how much they're eating is like breaking even. It's not necessarily causing a deficit, if that makes sense. That's a good question.
Is there a way to measure the baby's weight while it's in the placenta?
You mean in the
While
uterus?
it's
Yes, yeah.
inside.
So what you do is when you get your regular ultrasounds, you don't get the in-depth ones super often to take a look at those measurements. You get 2 to 3, but it's hard to really depict or to measure weight, and that's why they do the like crown rump length and the abdominal girth circumference to get a better picture of like if baby's meeting those milestones. So they can kind of project that you would have this size baby. So sometimes they're really spot on, and sometimes they're not. Like my best friend, who's my godson's birthday is today. A week before she gave birth to Will, they told her like, "Oh, you're on track to have about a 7-pound baby boy." And she birthed a 10-pound baby boy. And like, she was like, what the heck? Like and she actually gained less weight with Will, who's her second one, and didn't feel quite as big with Will. And she's like, and he was a much bigger baby. So they do the best they can, but obviously with any sort of measurement, you're gonna have a little bit of error.
Are there any like patterns of weight gain, like first child versus second?
Not necessarily. I mean, I think like I don't want to say wives' tale, but basically like I feel like my friends that have had a couple kids like will say my first child gained this, my second child gained this, and then like when you talk to your other friends, you're like, oh, for my first child, I only gained that much too. I think there's a lot of factors that go into that. Like if you have births very close together, like my sister-in-law just gave birth to her second one, and they're literally 13 months apart. She didn't lose any weight for her second, and gained quite a bit more weight for the second one, and so she may have gained about the same. The babies were about the same birth weight, but she herself gained, I think it seemed like she gained more because she's heavier now, but she may have just actually gained the same amount of weight. She's never lost the first one. But if you've like had a chance to lose the weight, maybe you're more active the second time around, or you were more active the first time around, that can also influence as well. So that's a good question though. I'm not 100% sure. I haven't actually seen any data on that. Okay. So again, this is just another graphic to kind of describe like again when weight gain takes off and where the majority of the weight is actually being attributed to. Okay. So again, really it's just the second and third trimester that you really see the more accelerated weight gain. You can see where it's deposited. Yes.
Is there a recommended time frame to
Afterwards, that is a good question. I know that there's a lot of studies right now looking into that area, particularly for women who want to have another baby. And again, it just really depends on a lot of factors. Like if you have like a mom that is gonna continue breastfeeding for more than a year, let's say, like you wouldn't necessarily say like you need to lose all this extra weight. Like, but again, like maybe they need it to actually support continued breastfeeding. If somebody who was already underweight to start, you wouldn't necessarily say like, okay, let's focus on getting back to your pre-pregnancy weight if we got you like up to a healthy weight. So I know that the sooner the better in terms of like continuing to carry like long-term like health risks as for anybody who is overweight or obese, but that's a good question that I think we're still trying to figure out. Okay, so weight-related concerns during pregnancy, kind of for the role of the RD. So really a big issue these days is that more women are entering pregnancy as obese or overweight, and they have a higher risk for preterm delivery, so less than 32 weeks, so it's pretty early, it's like 8 weeks early, or 5 to 8 weeks early, and higher risk for stillbirths. You see more issues with preeclampsia or pregnancy-induced hypertension. It can cause a lot of issues that we'll talk about. It's associated with lower serum levels of many of the micronutrients, especially like your fat-soluble vitamins and such, since they are typically sequestered in the excess adipose tissue. Also, excessive weight gain during pregnancy can result in larger infants and thus in more difficult and dangerous labor, especially if you have higher hypertriglyceridemia or hyperglycemia, and you have more glucose and fat being shuttled into the baby. You can have issues with greater rate retention after birth, which again can be an issue. And then pregnancy is definitely, though not a time for weight loss, so even though you may have women that are entering pregnancy overweight or obese, you don't actually tell them to lose weight because they still need to gain appropriate weight to support the pregnancy. So the focus is mainly on the before they get pregnant, or if they get pregnant and they are overweight or obese, to focus on the after and getting them to a healthy weight. So for those that have low weight gain, a lot of times you're really just kind of teasing out if there are any issues, dietary patterns, what have you, that you can focus on that are directly contributing to the low weight gain, and then counseling for those issues. And sometimes they aren't even the traditional things. You might find that somebody actually knows what to eat and how to eat, but they're getting pressure from family or friends not to gain enough weight. My husband had a patient one time that didn't want to gain weight and was scared to gain weight, and she was pregnant, and it came to find out that her family thought that she didn't need to gain weight because that's not what they did in their family, and so she was being pressured not to eat enough to gain weight. So there's sometimes like external factors that could be contributing. For high weight gain, again, it's very similar to low weight gain, but the biggest thing is kind of targeting any areas that could be contributing to that, but also just to not counsel to actually lose weight during this time. Okay, so we're going to move on to special considerations, but it's 9:03, so let's take a break for a few minutes and come back at 9:10. So we're going to go through some special considerations with pregnancy. So the ones we're going to focus on primarily today are adolescent pregnancy, exercise, or non-nutritive substances in foods and contaminants. I'm not going to focus too much on smoking. I have like a one-liner about it. Okay, so adolescent pregnancy I bring up because pregnancy in U.S. teens is still quite high, and you can have a lot of unfortunate poor outcomes when adolescent pregnancy if you can't get the adolescents connected to proper medical care. Your worst risk factors for outcomes are going to be a really young age, right? So, nowadays, technically, I think what's the average age of onset for menarche for women? I think it's like much lower. I think it's like 10 to 11 these days, which seems pretty low. So if you think about girls getting pregnant at like 13, 14 years old, like 14 seems pretty low, but I've seen it. There's a lot more going on, so you have the highest risk for a super young age. So conception after only 2 years of starting their period, they have low pre-pregnancy weight, and then they also have extra weight gain. They already are partaking in substance abuse, poor diet, or anemia. When I say poor diet, if anybody's talked to a teenager these days, the diets, or at least in the patients that I see at Children's that are not my athletes, are pretty lacking, to be nice. If they have any social emotional problems, or they have late or lack of entry into prenatal care, which is also a big one, especially if they don't feel they have social support and they try to hide the pregnancy, and then when it's finally, unable to hide it anymore, then they enter a care and it's like almost too late to try to correct some of those existing issues. And so a lot of the key things is to make sure that they are properly gaining weight. I had a really good question up here. It's Jacqueline, right? Yeah. That Jacqueline asked about, for adolescent pregnancies, do you have to also worry about like getting them enough because they're still growing? And that is the key, is that not only are you supporting weight gain for the baby, but you also need to think about that this individual is also still growing and maturing. So you need to make sure that they get enough to stay on target. So a lot of times it's working with them not only through diet, but most likely micronutrient supplementation as well. What about exercise in pregnancy? I get a lot of questions about this. Prenatally, if you have somebody who is very active, maybe almost too active in the sense that they're not eating enough to support having a pregnancy, a lot of times infertility, because they don't have have a period, can be reversed with reducing exercise and maybe gaining a little bit of weight. This happened to one of my friends who was a big kettlebell competer. She's in a lot of kettlebell competitions. She was very super active, and she and her husband were having a really hard time getting pregnant, and her doctor was like, maybe you just need to take it back a little bit, and she literally gained 3 to 5 pounds and cut back on the amount of strength that she was doing. She was still very active, but not as active, and they got pregnant right away. Right, so it doesn't usually affect first trimester pregnancy weight gain, but it can reduce your fat deposition and weight gain in the second and third trimester. So it's something to really think about long term. So it is definitely recommended to be physically active during pregnancy, though, in moderation. It does help with improving your fitness and reducing your stress. You do have to be careful at higher elevations just because of the lack of oxygen at those higher elevations. So for anybody, you have to be wary of that, but definitely for women who are pregnant, so that you can get in enough oxygen, not only for the maternal tissues, but also to be able to get enough oxygen into the baby. It has been shown to be helpful in preventing gestational diabetes. And also reducing pregnancy complications such as preeclampsia. And it does help with an easier labor because it helps with increasing your muscle tone, which is helpful for when you are laboring. So oftentimes you hear or see that women who report being more active during pregnancy or more physically fit have shorter labor times and easier times in terms of when they start having to push, the baby is able to come out easier, I guess. That's also an added benefit. High intensity exercise, you have to be careful of. There is safe limits, but it depends on your previous exercise habits. So that's one thing. If you have somebody that's entering pregnancy that's very active already, it is safe for them to continue to be at that level of activity. But again, really just trying to think about what activities they're participating in. So I played soccer and ran through my entire pregnancy, but soccer, 12 weeks, we stopped then because that was putting the baby at risk if I had a soccer ball kicked at my stomach. But before that, though, there was no indication. I checked in with my doctor. I also played in a league that everybody was a skilled enough soccer player that there wasn't any crazy me being taken out or anything like that. Okay. Some exercise, though, can cause bradycardia, so you do have to be careful with that. You don't want any irregular heartbeats, and you do have to keep in the back of your mind that some high-impact sports activities can produce urinary incontinence, which is something that happens especially later on in pregnancy, so the baby is getting larger and sitting more on your bladder. Okay? So I ran throughout my whole pregnancy, but definitely when I did my big event at 7 months, that trail running was not awesome for having to go to the bathroom all the time. So after that, we didn't do trail running anymore. That is very important, though. All right, what about non-nutritive substances in food? Can I drink coffee during my pregnancy or any other caffeine? Yes.
I have a quick question
Yeah.
relating to exercise.
Yeah.
So, you may talk about this later with pregnancy and stuff, but raising your body temperature, how bad is that for it? I know it's not really nutrition related, but how bad is that for the baby? Because with
Yeah.
exercise, can't you expect a degrees
You can.
raise in body
Yep, yeah, you can. That is a great question. So you can expect a few degrees raise in body temperature, but your body does like work to cool it back down. So there isn't any sort of like changes in your body's internal mechanism to cool back down. But that is something to think about. That if you're participating in exercise like in extremely hot weather and in conditions that would affect your body temperature, just to make sure that you are consuming enough fluids, that you're replacing any losses. So
that like short-term body temperature elevation is not
yeah, I don't know. That's a good question though, but no, at least from the recommendations that are out there and the research that I've read, no, and I haven't seen any other studies that have proven differently. I think it's more of when you are like long term, like not replenishing, or you're putting yourself in these like conditions where maybe your body's not used to that before. That's where it can be an issue. So like if you have somebody that like travels to the desert pregnant but is used to living in a mild climate and is there for a week, like that could potentially cause a little of extra stress if they're not taking care of themselves versus like just doing an exercise is fine.
And then as far as the baby goes, like is it protected enough where its body temperature is not raising, or?
Yes, yeah. And especially, especially when you think about like not only are they in like, the amniotic sac, and then they're in the uterus, and then you have your own like, fat. What is that? Not visceral. I can't think of the other type of fat that goes right here. Subcutaneous. There you go. Fat pad as well. So it's pretty insulated. And then you also have like the placenta working to like provide enough, fluid back and forth as well. It's a good question though. Okay, so can I have caffeine or coffee during, my pregnancy? You can. Caffeine does easily cross the placenta, so you can find it in the fetal compartment. There are some studies, like earlier studies, that show that high intakes were associated with spontaneous preterm labor, and there are later studies that show that it had no association with preterm labor. So safely, the recommendation is you can consume up to 300 milligrams or about 3 cups of coffee per day, and you're fine. Other caffeine content like, carbonated sodas, anywhere between 8 to 48 milligrams per 12 ounces. Energy drinks can have quite a bit more. Brewed coffee can range anywhere from 143 to 249, depending on how much, if you do like an espresso versus regular coffee. Right? Alcohol, you should not drink any at all. Even with one drink, can be associated with impaired fetal growth and the health of birth. The baby can then suffer from something called fetal alcohol syndrome, or there's now like a spectrum that's called fetal alcohol syndrome, fetal alcohol disorder spectrum, fetal alcohol syndrome spectrum. They now have like tried to break it out, so like depending on like what developmental abnormality you have, categorizes you as like a more severe FAS or less severe FAS baby. But you have anywhere from growth failure, facial changes, global developmental displays. It can occur with even moderate drinking. There's some really cool research going on with alcohol intake though, because there are some countries that the women will report that they regularly consume alcohol during pregnancy. And there are some, studies that show like, well, what happens if you have like a drink in the last trimester when like you wouldn't have like as great of an insult. So they are collecting a lot of data on this. I know when I left Davis, my lab was doing this study in conjunction with UCSD and a couple universities in the Ukraine, where women were very open and regularly reporting like how many drinks, what kind of drinks, and then they were collecting blood samples from like 8 to 12 weeks in pregnancy, and then like 20 to 24 weeks in pregnancy, and then right before they delivered, to kind of get an idea of micronutrient status and such. So I'm interested to see when the results finally come out with that. For artificial sweeteners, there's actually no recommendation. When you think about artificial sweeteners, you can find some of them in the placenta and some of them in breast milk if you're lactating, but there hasn't been any studies that have shown any adverse effects on the fetus or infant, but that doesn't necessarily mean that like you can't. I know that there's a lot of things that are often added to our food that we're still learning about, so most people avoid them, but there's really no recommendation if you enjoy having a Diet Coke or something like that. Okay, some contaminants that we do have to worry about when we think about our list of foods that we need to avoid as we're pregnant. So if you think about pregnant women and a developing fetus with an immature immune system, you want to make sure you're minimizing any sort of infection risk, okay? So, or toxins. So the big one that comes up a lot is methylmercury. And so a lot of times we find mercury in our fish sources. And we want to be able to encourage fish because we want to make sure that we can get a rich source of omega-3s because that's really important in development. So the key is that you need to take a look at your fish because your fish aren't created equal. So fish like shark, mackerel, tilefish, and swordfish have pretty high levels of methylmercury. And if anybody's ever used the the Monterey Bay Aquarium like Sea-Watch app, that gives you like a good breakdown of which fish. It gives you more information about where they came from, but also gives you an idea of which ones would have toxins like mercury in there. Right, so we say to eat anywhere from 8 to 12 ounces or a variety of fish per week. If you're taking a look at those like omega-3 rich sources, a lot of times that comes from salmon, it comes from tuna, it comes from flounder, and it comes from trout. So the other kind of like biggies that most people eat. And so why is this a big deal? Is because high intakes of methylmercury has been associated with impaired nervous system development. Okay, so that is something that you'd like to avoid. PCBs are another avoidant. So this is also found in the fatty flesh of large fish from directly affected areas. And high intakes have been associated with learning and behavioral difficulties. Again, if you use something like the Sea-Watch app, they kind of give you an idea of where that fish came from, and they identify them as like red, yellow, and green. So red would be, this might be a high risk fish. It can have mercury, it can have a contaminant. Green being like this was, caught, long line caught, whatever, in a good area. Another one that you need to worry about is listeria. This is found in raw milk, smoked seafood, like basically any of your like kind of deli meats and soft cheeses. And high intake is associated with spontaneous abortion and also meningitis of the fetus and newborn, which can be very scary. So unfortunately, brie, not okay. Unpasteurized foods, not okay. Which can be a little bit of a bummer. Prosciutto, not okay. So, which sometimes you don't think about those things when you're out at a dinner party with friends. So you have to be careful. One other bacteria that comes up often that is not necessarily a food that I always bring up though is toxoplasmosis. Is the issue usually from handling cats or like cat litter. I actually had a friend in college whose mom worked with the large felines at the San Diego Zoo and didn't know before she was pregnant and actually gave it to her son who ended up being partially blind in one eye. But he was still a fabulous picture after 2 days. But so it does come up. So if you have a cat, normally you have to have your partner or roommate take care of the cat and cat litter box, which may be a nice thing. Or have somebody else do it. Okay, so we're gonna talk about some physiological changes going on in pregnancy. Okay, so what goes on during pregnancy physiologically? So you get a large increase in blood volume, okay, about 50% increase, okay? 20% of that is coming from an increase in your red blood cells, and 30% of that is coming from plasma, right? So this increases urinoflorium and water retention. Okay, so we need to think about, we want to make sure that our kidneys are working well, and there's some mechanisms that go into place to help with handling this larger volume. Okay, the plasma concentration of most nutrients because of this increase in volume falls, except for your lipids and fat soluble vitamins, of course. So it is something that you do need to worry about, especially when we talk about like iron and some of the other micronutrients. To also accommodate for some of this, this large increase, your heart size does increase a bit, and your pulse rate increases at first, and then kind of levels off, and this is really due to vasodilation and the increased oxygen requirement as you're increasing this blood volume. Your BMR increases as well, and it does so in a little bit more in larger women. And then your GFR, your glomerular filtration rate, so how the rate at which your kidneys are actually filtering everything out, does increase. But you do get a little bit of leakage of protein and other nutrients into the urine. So that is accounted for when you are taking any labs, so they know that there's going to be a presence of some glucose, some proteins in your urine. It's just when you get to the too much of that is when it becomes an issue. All right, so other changes that take place. We're going to talk about GI changes. We're going to briefly talk about gestational diabetes. We'll talk more about diabetes next semester. We're going to talk about renal function, and then pregnancy-induced hypertension issues. Yes?
For the increased oxygen, is that because of the baby or because of
Both.
the concentration?
Both. So you need more to be able to get into the baby, and also because of the larger blood volume. All right, so nausea and vomiting, unfortunately, does occur in most pregnancies. It doesn't occur in all pregnancies. Typically, earlier on, you hear a lot of women complain about being very nauseous during their first trimester, and then the second trimester, comes in and they feel much better. A lot of this has to do with hormonal issues, and so that is normally the cause of it. So what do we do for nausea and vomiting? We usually just encourage, small frequent meals. A lot of women say that just simple carbohydrates, crackers can help out if they're having a bit of nausea. Some people wear the nausea bands. I have a coworker at work that really likes the nausea bands that you wear if you were to get seasick. So those worked out well for her. Liquids between meals. There's a little bit of evidence that shows that you can have ginger or even a little extra B6. Not super strong evidence though, but I've had some patients talking about that. Occasionally, IV fluids are needed if there is excess vomiting and excess loss. Constipation, unfortunately, happens, especially because you get reduced gut motility, and oftentimes as pregnancy progresses, women are not necessarily as active. So if we think about constipation, a lot of times we say have more fluid, move around, have more fiber in the diet. So it's usually our first go-to. The other thing that causes really bad constipation is if you have a woman that has to take iron supplements. Raging constipation, not fun at all. Heartburn also comes up. A lot of this has to do not only with hormones, you get a relaxing of the lower esophageal sphincter, but you also get extra pressure on the stomach because of the developing baby. That just kind of contributes to that. So we would actually provide the same sort of M&T that you would for regular patients that would have GERD or reflux disease, small frequent meals, liquids between meals. Try not to eat and then lay down. If they've identified foods that are super fatty, super acidic, unfortunately chocolate, mint, that might contribute to heartburn. We have to avoid those. And then another item that often comes up is something called pica, and it's when you're eating non-food items. And when I say non-food items, like dirt, paper, rocks, things that we would not really necessarily consider food. There's some thought behind this that these are individuals that may actually have a base borderline nutrient deficiency, and so this is a subconscious way of actually going and getting that nutrient. Some people think it's a superstition and that really doesn't happen, or that maybe that you should be consuming these items for whatever reason. It's kind of difficult to treat. However, usually you just try to substitute foods that might mimic or might provide maybe the nutrient profile of a piece of paper would. So it doesn't come up very often, but it does come up. All right, so gestational diabetes. So gestational diabetes is when you have insulin resistance during gestation. So this is not somebody who had diabetes and then went into pregnancy. This is they only got diabetes during pregnancy. It happens in about 5 to 6% of all women who are pregnant. You get something, every woman has to get an oral glucose tolerance test at 24 weeks, and that's when you go in, you drink a specified amount of glucose in a very sweet beverage, and then they test your blood usually an hour after you consume that to make sure that your blood sugar levels have gone down into the normal range, so that your body is able to process that. So if you have gestational diabetes and you don't pass your test, they usually do a little bit more testing to make sure that you actually have gestational diabetes, so you'll have to go back in and drink more, and then they do a longer blood test amount. Gestational diabetes is associated with an increased risk of preeclampsia or pregnancy-induced hypertension, fetal morbidity, and mortality. Infants can be born large. This is known as macrosomia, just because you have excess blood sugar hanging around because the mom isn't able to take everything in, and so it's going to be completely absorbed through the placenta and get into the baby, which is going to facilitate rapid tissue growth. Okay, if the babies are too big, that might actually indicate a need for delivery via C-section or cesarean. And then also there are studies that showed that these babies who are born very large or have they have impaired glucose metabolism also later in life. So we usually try to be careful of that. Question?
Is the 24 week at the side trimester, or is it at
So it's right in between the second. It's the like weekish between the end of the second and beginning of the third trimester.
do you know why it's not?
I have to remember the recommendations for it, but I think it's because there's been. I'd have to review it. Part of me thinks it has to do with the fact that like at that time point, like you have enough fetal growth to see if accelerated growth would be going on. But it also has to do with where like your hormones are during that phase in pregnancy as well, and then you would actually start to see more issues with gestational diabetes or like higher hyperglycemia, just because of how far along like the baby is growing. But I'd have to double check. It's a OB medical guideline, so I'd have to like recheck into that. If you email me about that, I will take a look at it. Yes.
Someone who has type 1 diabetes,
Mhm.
do they have the same risks as someone who has gestational diabetes? Or
They
worse?
do, yes. So it depends. If it's a poorly controlled type 1 diabetes, they could have higher risks. If it was a well-controlled, it might just be the same risks. So gestational diabetes is controlled by diet and activity primarily. However, if you do have a woman who, even with diet and activity, cannot keep her blood sugars low enough, then they do start insulin. My sister-in-law has had gestational diabetes, I swear, for the last 2 years because she got pregnant very soon after having her first child, and she had diabetes with both of them. And unfortunately, her blood sugars were so high. I'm so surprised both of her girls were not large babies because she was on very high amounts of insulin, like more than I like see regular patients on, to keep her blood sugars under control. She tried doing diet and activity for 2 weeks, and she was so good and so strict, and her blood sugars were still really high, and even with her insulin, they were high. So you can have insulin intervention as well. You do need to make sure that you be careful to not go into ketosis though, because that can be dangerous to a pregnant woman as well. So you still need to make sure that they're getting enough carbohydrates. We don't say minimize carbohydrates, but we'll go into gestational diabetes counseling next semester a little bit more. Mikkel might touch on it like a touch in the case on Monday, but I can't remember if she's doing that one or not. Okay. Yes. Oh yes, and pre-existing diabetes, a lot of times they'll need less insulin the first half of pregnancy, but again, it's individual specific, and it has to do more with hormonal changes, and then more after 5 months into pregnancy, and again, just because of the hormonal changes in pregnancy. Okay, so renal function, so our kidney function. So to account again for this increase in blood volume, you have the involvement of your angiotensinogen hormones to help with basically relaxing things. So basically you have your vasoconstrictive stimuli, such as angiotensin 2 and norepinephrine, to progressively decline and relaxin to increase, allowing blood flow. So basically you get an increase in relaxin, and you get a decrease in more of your vasoconstriction, angiotensin, and your norepinephrine. So basically the overall effect is you have more openings to let more fluid come through to allow for that excess blood volume that we have. But because of the more opening, that's why you do get some loss of protein and nutrients into the urine, a little bit more, but not too much. Okay, so you get an overall 50% increase in GFR, meaning that your body begins to filter things out quite more rapidly, which is why you sometimes feel as if you have to go to the bathroom a lot more, and you don't actually go to the bathroom that much, just because your body's becoming a lot more efficient. Okay. However, if this relaxin binding and vasorelaxin takes place, you do get restricted blood flow, and then you get hypertension. And this is can be very dangerous and scary, and it's considered preeclampsia in pregnancy. So you get pregnancy-induced hypertension. So in pregnancy-induced hypertension, preeclampsia, you essentially have hypertension, you have excess protein in the urine, so you have more than what would be expected, and then you also have edema because of this lack of, because of this restriction of blood flow, right? So if that does then involve poor blood flow to the uterus and as well then to the fetus of unknown etiology, so that's not good because then you're not being able to get your nutrients and oxygen to your baby. Okay, so you get increased risk if you are somebody who is promucarious as a family, which is having a personal or family history of preeclampsia, family history, chronic hypertension, so where you have hypertension going into pregnancy, if you're obese, if you have type 1 or type 2 diabetes going into pregnancy, if you have chronic renal disease, and if you have a maternal age of greater than 40 years, which is happening more and more these days. Okay? In actual eclampsia, so let me back up. So women who are pre-eclamptic start to become monitored very closely. A lot of them go out, end up going on bed rest, and are coming in on like a weekly basis to have their blood drawn and their vitals taken to make sure that they don't need to go in for pre-delivery. If you have a patient who actually has eclampsia, you can have some very detrimental and very horrible things happening to the mother, including intracranial hemorrhage, pulmonary edema, renal failure, and then seizures at delivery. So it's actually very scary for the mom. We do not sodium restrict and we do not provide diuretics because one, it has been shown not to help, but two, diuretics aren't specific, so it's not going to just take fluid away from like where the excess fluid is. It's going to take fluid away anywhere, so you can actually have a dehydrating effect because the moms can then become intravascularly depleted, which then means that nothing also is going to the baby. There's been some studies to show that magnesium can help in the treatment and maybe calcium supplements, but only if the mom's intake is low, like really low. I haven't actually seen calcium supplements used when I've worked with pregnant women, but it has been shown to be beneficial. All right, questions before we move into actual nutrient requirements. I know, lots of information today, lots of information next week too. Yes?
How is the encapsulated treated? They actually have it.
Oh, yeah, a lot of it is monitoring, and a lot of it is, it's completely medically managed at that point. So a lot of it is monitoring, a lot of it is, what's the other thing that they do? A lot of it is bed rest, a lot of it is fetal monitoring to make sure that they're okay. They don't really restrict fluid, unless it's like excess fluid, like edema, like they might restrict a little bit, but not too much to make sure that they're getting enough in. Off the top of my head, I don't have any like medications that I know that they would regularly use. I just know that they're more often than not closely monitored. I have a cousin whose wife has type 1 diabetes, and she had preeclampsia, I think, with her second pregnancy. And basically, she had to go on immediate bed rest and basically had to go to the doctors every week just to monitor to make sure that she was healthy and the baby was healthy. But I don't remember her having to do any other medical intervention besides just making sure that her blood glucose was under control. So, but I would not be the best source for that. I would have to look that up a little bit more. If you want me to, I can, because I have OB friends who would be able to tell me that. So just email me and I can look that up. Okay, nutrient requirements. All right, so energy requirements. So finally, we're getting into some more nutrition stuff. So there's a lot of stuff that's going on in pregnancy. Lots of growth going on. Higher BMR for the mother. We've got an infant that's growing as well. So we do have an increase in energy requirement to cover the cost of that. However, it's actually not that much. Most people, again, that fallacy that I have a baby, so I'm eating for two, you don't really need that much. If you looked at the whole span of like the 10 months or 40 weeks of gestation and how much you actually need, it's only like 260 calories per day. 260, like 280 calories per day. And when you break it out by trimester, because there's not a lot of growth going on, we actually don't have any recommendation for increased energy need in the first trimester. You say to eat what you regularly be eating, energy needs what you regularly be calculating for any other person who's not pregnant. It's during the second and third trimester only that you would actually increase energy needs. Of course, the caveat is if you have a patient that's coming in who's already underweight and you need them to gain weight, then during the first trimester they may be in little extra needs. But for the second trimester, needs are only an additional 340 calories per day. Third trimester, an extra 452 calories per day. So not really that much extra. You can easily get that from quite a few things. So if we're not getting enough, it's going to restrict weight gain and thus restrict birth weight. So you want to make sure they're getting enough. You don't need too much. All right, protein requirements increase some. Okay, so the regular RDA for protein is 0.8 grams per kilogram of body weight. It does go up to 1.1 grams per kilogram per day during the second half of pregnancy. This is really for the additional requirements for deposition of internal tissues as well as fetal growth. And most pregnant women don't have any problem consuming this, but it's always good to double check, especially if you have women that are, avoiding certain products, if they're, strict vegan, vegetarian, or they're not, taking any fish or certain meats or whatever. You just want to make sure that they are getting enough protein sources from, non-animal, non-plant-based proteins. Okay. So your recommendation is really balanced energy protein supplementation or intake to improve fetal growth and to help reduce the risk of fetal and neonatal death. Okay. All right, recommendations for other nutrients, carbohydrates. There is a DRI for carbohydrates in pregnancy. It's 175 grams per day is the adequate intake. The estimated average requirement is 135 grams. So we say to at least get 175 grams of your adequate intake today. You just want to be able to provide enough so that we're not going into ketosis and we're not utilizing the protein to be able to provide that energy. Fiber, we do encourage intake of whole grains, breads, and cereals, and to get up to about 28 grams per day because, again, constipation does happen because of the reduced gut motility of those physiological changes that take place during pregnancy. For our micronutrients, I'm going to bring up 3 in particular, vitamin A, folic acid, and vitamin B12. There was another textbook that I was reading when preparing for this lecture, and they bring up vitamin D. And there's nothing really to add much to it for pregnancy, just that a lot of women and adults in general are deficient these days or insufficient. So to make sure they get enough, we'll talk about vitamin D for lactation for women because they do need it if you're exclusively breastfeeding. We're going to talk about vitamin A, folic acid, and B12 today. Vitamin A is more of an issue with toxicity versus deficiency. Folic acid, we're going to talk about the role of preventing neural tube defects in B12 because it can be a nutrient that is deficient in certain populations. So vitamin A is an issue for overconsumption more in the US, especially if you're taking a lot of supplements. And that's because it's considered a teratogenic agent, which means it can cause birth defects. So if anybody has ever had to go on Accutane medication in here, typically you have to have education around that you will not get pregnant or try to get pregnant while taking Accutane because it's a form of vitamin A. And it's a really high form of vitamin A, and it is extremely teratogenic. We have to do really high Accutane doses for one of the studies for my oncology kids. So even though the kids are like 2, their parents have to sign consent that they received education that their child will not try to get pregnant while on this medication. It's a very serious thing. So even though they're 2 and not even able to get pregnant, they still have to sign documentation that they got the education around this. In developing countries, deficiency is more of a common, and so for a lot of these international studies, you will see that supplementation, as part of supplementation, vitamin A is included because it does help with decreasing maternal mortality and morbidity by over 40%. So it is very effective. You want to make sure that you are definitely getting enough vitamin A. Okay. Folic acid. So folic acid is a big deal just because if you remember back to the beginning of the talk, we talked about that, within the first 4 weeks, we start to see nervous system or central nervous system development. And that's really key because within the first 28 days of life, our neural tube is actually formed and should be closing. And folic acid is very important with helping to actually get that neural tube to close. And so if you're thinking about women not knowing that they're pregnant until after those 28 days or right around then, you may have missed the boat in terms of making sure that they have enough folic acid to help support the proper neural tube closure. So what happens if you don't have proper neural tube closure? You have something called a neural tube defect. There is a couple different presentations of this that we'll talk about in the next slide. But the key thing with folic acid is that we really try to capture these individuals before they get pregnant. And so that's why all of our flour and a lot of our grain products have been fortified with folic acid since 1998. And when we take a look at some of the literature that shows like what neurotube rates were before, the requirement and after the requirement, there was a significant decrease of neural tube defects in the U.S. 35 to 70% decrease in neural tube defects in the U.S. for women who took the folic acid and multivitamins, and 71% in a study with 400 micrograms for women at risk of recurrence. I'm sorry, so this wasn't even the literature for folic acid fortification. This was for specific supplementation trials. For folic acid fortification, the rates were, I think it was 55% in the US and like 45 to 50% in Canada, because Canada also folic acid fortifies most of their grains. So that's a big deal. It's a huge deal to actually without having the women do anything besides just continue to consume food because we fortified their food, to have like that decrease in neural tube defect outcomes. So the recommendation is to make sure that there's enough 400 micrograms from supplements or from diets for all women capable of becoming pregnant. Okay, so neural tube defects. So the neural tube runs from brain all the way down, right? So if you don't get improper closure, what can happen is you get something called spina bifida. And so you basically get this outpouching right here of the neural tube. And this can be very minor, whereas like some people, might actually have an opening, they don't even know it, they're functioning fine, there's no like secondary issues, or it could actually cause this huge outpouching, which can be, paralyzing, can be uncomfortable, can cause a lot of like physical limitations. In really, really severe cases, you can actually have improper closing up, to the brain or brain stem, and also known as anencephaly. And so you have somebody that a baby that maybe not even make it to term because of that. So, it was decided that it was important to make sure that we prevent this from happening. So that's why all of our grain products are now folic acid fortified. Anybody hear any of the evidence of why that might have been a bad thing for our country, for other countries? We talked about that in classes. So remember, we always talk about unintended consequences if we do something. Has anybody ever been in a class where they discussed like why might that been a bad thing? Katie, you guys talk about that all in your graduate classes? So why it might have been a bad thing, or what's a potential unintended consequence for folic acid fortification? Because remember, if we're fortifying our food for all women to consume it, right, because it's not just women that are consuming, men might be consuming cereal as well, right? So anyone's consuming cereal. So why might too much folic acid be a bad thing? Maybe some in the literature. So, yeah.
If there's a vitamin B12 deficiency, it can like mask it.
That definitely. So yeah. So that's one thing, is it could be masking other deficiencies. The big one that's come out. So I'm looking at time. I don't really have time too much to talk about this, but it's an interesting point. Is there's been a lot of literature taking a look to see if, because we're now folic acid fortifying, everybody's getting so much folic acid, is it increasing our rates of colon cancer? And so there's a body of literature like taking a look at, providing too much folic acid and going through that one carbon metabolism, because again, folic acid is really important in DNA replication and synthesis. And so, is that causing an issue with, something like cancer and repeating, the synthesis and replication? Is that the case? I have no idea, but there is some interesting literature coming out to make sure that, again, when we're making these very large scale decisions, like, was it a good idea to folic acid fortify? Well, yeah, we now have less individuals with neural tube defects that can have lasting effects, but now do we have more people with colon cancer? I'm not 100% sure, but there are decisions that we make when we make these. So, anyways, something to think about. Okay, vitamin B12. So why this is brought up is that it's very common in lower socioeconomic status populations, particularly if they're not purchasing animal products, because remember, B12 is the only water-soluble vitamin that's actually stored, and it's found in anything that has a liver. So it has to come from an animal product or fermented foods. So most people get them from animal products. But it's okay, you can get it from other products. But if you have somebody who is vegan or very strict vegetarian and not eating any sort of animal products, and lacto, ovo, what have you, you want to make sure that they are being supplemented with it. Those that are deficient in pregnancy, you will have an infant that is born, low vitamin D stores, and also her breast milk will be low, and then her infant will continue to be deficient. So low B12 has been associated with neural tube defects as well. Growth retardation or restriction, cognitive problems may also be permanent because of this. So really, we just need to make sure that we're capturing any women who are limiting animal products or not eating enough other products, like fermented products, to get a vitamin B12 supplement. Ooh, what's happening? Seriously? Awesome. Ooh. Sorry. Sorry, I got all my words written. Okay, I guess we're gonna start over. I'm actually here. All right, so the picture is taken at Tilden, by the way. A nice fog day. Okay. All right, so our minerals that we're going to talk about: iron, zinc, and copper, calcium, and iodine. And actually, we're not really going to talk about calcium that much. I just bring it up because it's interesting. Most people think like, oh, you're growing a whole new skeleton. You're going to need an increase in calcium. And really, there's no increase because during pregnancy, we ramp up our absorption capacities and we go from being able to absorb like 30% to like 50% of all calcium. And so we actually don't need any, and we also lose less in our urine. So we don't have any increase in need. Okay. Iodine, I'll bring up really quick, it's key because if you're lacking in iodine, it can be also very severely detrimental because you get something called cretinism, and it also increases infant death. So supplementation is often key in many countries. In our country, it's not as big of an issue, especially if you're using iodized salt. So it's another food product that was fortified to make sure that we were getting enough iodine. So iron deficiency in pregnancy, and somebody had asked about iron before, is and can be an issue, and it's very common in adolescent, pregnant and postpartum women, even in industrialized developed countries. If you have low iron stores at conception, there's a very high risk of anemia, and more often than not, you enter and continue into pregnancy already at a deficit. So if you have early iron deficiency, you may actually trigger preterm delivery and or low birth weight. So we really try to make sure that we capture the before, so you're not entering into pregnancy deficient and then continuing deficient. There is a question about whether or not we should routinely supplement pregnant women during the second and third trimester. In some OB practices, they do, just to make sure. In other OB practices, they don't. I was not regularly supplemented. My hemoglobin continued to come back normal, so there was no need to, but I know some friends that were told I have to start, iron supplements, and their hemoglobin was normal. So there's still a little bit of contradiction about whether or not we need to. The pros for supplementation is that it does help with maintaining, to be not anemic. It may reduce low birth weight and preterm delivery risk. It can improve infant iron status 2 to 6 months. It may be important for infant cognitive development. And these are all big maybes because we need a little bit longer follow-up for these individuals that have gone through these trials of supplementation to see like if the cognitive effects are lasting. Okay, cons. Iron's a toxic metal, right? If you have too much of it and we're storing a lot of it, it can be toxic, and it's very unstable molecule as well. Also, really high hemoglobin levels are associated with low birth weight and IUGR, and also prematurity and perinatal mortality and morbidity, and other complications of pregnancies. We don't want to do too much. So it's a delicate of the too much to too little. So I think more often than not, you are identifying women who are at risk and would benefit from those supplements, and also if they're going to actually take them. So ideally for any of these micronutrients, you're really trying to treat before. Again, going back to that developmental milestone slide from the beginning, you want to make sure that you have somebody entering into pregnancy as healthy and nutritionally adequate as possible to really help with, reducing any sort of complications or developmental effects in terms of poor outcomes for development. Also, preterm delivery is programmed around 16 weeks, so you also want to make sure you're capturing before that as well. Okay, and a lot of times care often starts later in pregnancy, second or third trimester, which can be too late. So again, that's why we're trying to focus on the before. So many women don't eat an optimal diet, especially adolescents, which is why they're under the special consideration category. Higher nutritional requirements for both administration compounded by pregnancy and lactation make it very difficult for people. So some food habits to consider when you're meeting or working with pregnant women in clinic, is that if you have somebody who is vegetarian and has low meat and or dairy products, you can safely be a vegetarian during pregnancy. It's just, again, making sure that the diet is actually adequate enough to meet all of those needs. Consuming too much fat and sugar and too few fruits and vegetables, so again, the balance of nutrients and food sources. Skipping meals, trying to lose weight, drinking too much soda, alcohol, coffee, smoking as well can increase nutrient needs, can also can cause some developmental abnormalities. Okay, so this is just kind of the snapshot summary for general recommendations for pregnancy. I know that I'm definitely not going to be able to get through lactation. Every year I ask Mikkel, can I separate these lectures, but she thinks that I can get it in. I really can't get it in, but it's okay. On Wednesday, so you're going to do a pregnancy case with Mikkel on Monday. On Wednesday, we will go through lactation. There's not too many of these slides, and I'll just combine it with our healthy peds since it kind of flows into that anyways. We'll talk about lactation and infancy together, just so that you're all prepared. So any questions? I know this was so much information. Okay, nothing yet, okay. If you have questions that come up, or as you are working through your case on Monday with Mikkel,